right, good afternoon, everyone. This is the posted time and place for the Silver State Health Insurance Exchange. We are teleconferencing today between Carson City and Las Vegas, and we do have telephone participants. In order to keep the phone lines and the lines clear between Las Vegas and Carson City, if you're not speaking, would you please mute your phone line? And then also for participants on the telephone, if we can get you to mute your phone line unless you are speaking. And also, please know, if you put us on hold, if you're on the telephone line, it usually puts through music and disrupts the meeting. So please do not put your phone on hold. Just use your mute line on it. So with that, I am going to welcome everyone here for this meeting today and ask Mr. Hager to take the roll call.
Ms. Atkins?
Present.
Ms. Lewis? Does not appear to be here. Dr. Klein?
Here.
Ms. Kerr?
Here.
And Ms. Kerr is here by phone. Dr. Ford?
Present.
Director Wilden, I believe, will be here shortly. Mr. Johnson, or Director Johnson? Director Mullenkamp will not be able to make it today. Vice Chair Johnstone?
Here.
And Chair Smith, or Chair Campbell, excuse me.
That's all right. Present.
We have a quorum.
All right, thank you very much. This meeting today is held for the special purpose of a selection of Nevada's essential health benefits package, and that will be the only item of discussion on the agenda today. Agenda item number 2 is public comment, and before we get started on that, I wanted to just put into the record all of the people that we have received public comment from. All right, prior to today's posting, we've had public comment from the Nevada Chiropractic Association, the National Partnership for Women and Family and Childbirth Connection, American Heart Association and American Stroke Association, the Nevada Dental Association, Western Bariatric Institute, Human Services Network, John Dawson, Diane Ross, Healthy Aging Program, Keith Osgood, Elizabeth Feldes, leading groups in the obesity community, Nevada Optometric Association, State Patients Equal Access Coalition, International Melanoma Foundation, ESAE Inc., Legal Services Statewide Advocacy Coordinator, Pharma, Delta Dental, NAPA, Sally DeArmondorf, VSP Vision Care, Autism Commissioner, Karen Advance, and then with our posting for this meeting, we've had additional public comments, and all of these are written comments, from Lung Cancer Alliance, Nevada Optometric Association, Human Services Network, Nevada Advocates for Planned Parenthood Affiliates, Susan Demas, Nevada Speech Language Hearing Association, Jamie Selby, Advanced Pediatric Therapies, Washoe Legal Services, and Heather Lewandowski, I believe is how you pronounce it. So those have been the written comments that we received and have put into the record. I am going to open it up for additional public comment now. If you have sent something in and I didn't read your name, please come forward, and this would be the time and the place for public comment. So I will start in Las Vegas. And if I could, if whoever's speaking, we need to have you identify yourself for the record. and we will limit public comments to no more than 3 minutes.
I'll talk loud, I promise. Good afternoon. For the record, my name is Barry Gold. I'm the Director of Government Relations for AARP Nevada, and I thank you for the opportunity to speak to the board today about this important issue of selecting the plan. AARP Nevada represents a wide variety of our members across the state, over 315,000, and not all of them are on Medicare. A lot of people think, well, why is AARP at the table? Well, we have members of all ages. While we're considered to be 50-plus organization, those people 50 to 65 generally do not have Medicare, and then we do have members that are younger than that. So what AARP is urging the board to consider is to pick the plan that is the most comprehensive and offers the most services that will meet the community needs, with an eye, of course, to affordability. Some of the plans offer different things. Looking at that comprehensiveness gap, I think it's important that you pick the one that is the most comprehensive. Some of the things that affect AARP members considerably would be vision and hearing. When I testified at the state legislature about Medicaid services with vision and hearing, I turned off the microphone, and so when I talked, none of the elected officials could hear me. And then I turned the microphone back on, and I said, that's what life is like if you don't have hearing, and why hearing aids and hearing exams are really crucial to be included. And they came up to me afterwards that was really significant that you put it that way, because we really didn't understand. It's not just simply an inconvenience, it's a way of life. And the same thing comes with optometry exams. If all of us were to be forced to wear the same pair of glasses for the rest of our lives and not get another eye exam, many of us would become functionally blind. And so it's not just an inconvenience. There are services that are really crucial. So we urge the board to look at a plan that is the most comprehensive and provides the services that will be needed by people. Thank you.
Thank you. Is there anyone else in Las Vegas?
Yes, somebody else is coming in.
Thank you, Dr. Klein.
Good afternoon, committee members. For the record, I am Jan Crandy, a member of the Nevada Commission on Autism Spectrum Disorders and a care manager for our Nevada State Autism Treatment Program. I am here to address agenda item 3C and to voice my concerns with this document provided by Aon Hewitt. First, the document states a typical ABA program includes 20 hours of ABA work a week. When passing AB 162, effective treatment is what legislators wanted for children with autism. Research supports at least 25 hours a week, with most indicating 30 to 40 hours a week. I am including with my testimony the health plan coverage guidelines developed by the National Behavior Analyst Certification Board. These are the specialists recognized nationwide to treat autism. This document defines treatment dosage. It also outlines the tiered service delivery model.
If you could stop for a minute, we've just lost all the audio with you.
Can you hear us?
Yes, we can now.
I'm including in my testimony the health plan coverage guidelines developed by the National Behavior Analyst Certification Board. These are the specialists recognized nationwide to treat autism. This document defines treatment dosage. It also outlines the tiered service delivery model. This service model allows for a cost-effective delivery of treatment, utilizing paraprofessionals to deliver the bulk of the treatment hours. The bill stated a maximum benefit of not less than $36,000 per year for applied behavior analyst treatment. Other therapies were outside of this cap. The goal of autism advocates has always been to support research levels of treatment hours. We have successfully done this in Nevada by keeping the cost down. Insurance should not drive the cost up. I am including the state's autism program rates, currently paying a maximum of $160 an hour for BCBA level personnel, with a typical month billing only 4 to 6 hours. A maximum hourly rate of $25 an hour for paraprofessional staffs called interventionists, who can then deliver at least 25 hours a week. Average hourly rate paid by the state is currently $15 an hour. Clark County School District also funds interventionists at a high of $12 an hour and has done so for 13 years. I asked this committee to define hours rather than visits. In my review speaking to providers statewide, insurance doesn't understand ABA treatment and the service delivery. Insurance is paying a range between $85 and $135 an hour for BCBA level personnel and between 3 and 6 hours a month. TRICARE's plan, whose benefit is $36,000 a year, supports 2 to 4 hours a month, with the rest going to support weekly treatment hours. If we take the higher insurance paid rate at $135 for 6 hours a month times 12 months, that only equals $9,000 a year, which leaves roughly $26,000 for weekly hours. Delivered by interventionists at the state high of 25 hours would be 1,051 hours a year or 20 hours a week. Insurance companies in Nevada are currently approving hourly rates for interventionists ranging from $28 to $50 an hour, with the average, I'm guessing, about $38 an hour.
And that's 3 minutes if you could wrap it up.
Okay. Today, this committee has the power to keep the costs down by supporting a tiered service delivery model and supporting 25 hours. I would also like to state that I hope that you guys elect Plan D as the chosen plan, as it is a more comprehensive plan specifically in the areas of therapy with no limits on physical, occupational, and speech therapy. Thank you.
Thank you, Ms. Grandy.
And I do have all this written with all the documents, so I'll submit them.
Thank you. Is there anyone else in Las Vegas for public comment?
Good afternoon, and for the record, Dr. Mark Lee of the Nevada Optometric Association. The Plan Certification Committee has recommended that the board choose between Plan A, D, and F as Nevada's benchmark plan. All 3 of these plans provide for a comprehensive annual vision exam for the children's essential benefit. However, none of these plans provide a corrective hardware benefit. Plan D covers glasses one time after cataract surgery, which in a pediatric population is probably not much of a benefit. And while Plan F provides for a 20% discount, there is no defined hardware benefit. As a provider who sees children every day, I feel that it is equally as important to diagnose vision problems as it is to treat them. In a December bulletin, which we've provided in our written comments, CMS recognizes that many plans have incomplete coverage for the children's essential benefit. Therefore, they have laid out a method to supplement the benchmark plan to provide meaningful coverage. On behalf of the children and optometrists of Nevada, I urge you to supplement the benchmark plan you choose with the federal employee vision plan with the highest enrollment to provide a complete children's benefit, covering both an annual exam and corrective benefits. Thank you for your time and consideration and your dedication for setting up this exchange.
Thank you, Doctor. Anyone else in Las Vegas?
No one else here in Las Vegas.
All right, thank you, Dr. Klein. How about here in Carson City?
You hold it. Hi, my name is Christy McGill with Healthy Communities Coalition of Lyon, Story, and Mineral Counties. We did look at all the plans, and although they were a little bit confusing for us, we did think that Plan D was a little bit more comprehensive and may help. In the last couple of years, we've been working with access to health care for our rural Nevadans and find that the most comprehensive plan becomes easiest to be able to bridge that gap with access. So thank you very much.
Thank you.
Good afternoon, Madam Chair, members of the committee. My name is John Sasser. I'm the Legal Services Statewide Advocacy Coordinator representing Washoe Legal Services and the Legal Aid Center of Southern Nevada. I also serve on the Commission for Services for People with Disabilities for the state. And I'm here today to ask your support for choosing Plan D. As everybody else who's come to the table has mentioned, Plan D is the most comprehensive in terms of the services. All three plans fail to cover eyeglasses, as we just heard. But Plan D covers all of the other enumerated services, while Plan A does not cover optometry exams or speech hearing exams, and Plan F eliminates hearing aids and optometry exams. Second, there's a gap in service limits. Most of all, in the categories, D is the most generous with no limits on physical, occupational, and speech therapy, rehabilitation, hospitalizations, and durable medical equipment. The only limits that are more restrictive in Plan D, other than in the other plans, are the 60-day skilled nursing facility limit. Plan A has 100 days, while F has 30, and the home health care with 60 visits. Finally, the drug formulary, which I'm certainly much less expert in, I also believe is more comprehensive in Plan D. You have a choice to make, looking at affordability versus comprehensiveness. There's a significant gap, a score of 5 for Plan D and a score of 3 for the other plans in terms of comprehensiveness. I don't believe, however, the gap is nearly as big or large in affordability. Plan D is rated the least affordable, but only costs 3.5% more than what the cheapest plan was, which was Plan C. Plan F is 1.9% more, but Plan C has by far the more restrictive, Plan F is 1.9% more than Plan C, but has by far the most restrictive limits on rehab services, skilled nursing facilities, and rehab hospitalization. While Plan A is 1.5% more than Plan C, it's my understanding that it does not have a pediatric dental benefit, which will require a dental rider at additional cost. So for roughly 1.5% more, we get a plan that is far more comprehensive, and I think it makes it, at least as to the low-income folks that we serve that will have subsidies in the exchange, it makes much more sense to have comprehensive services. It's also better for the providers, and for those who are in that unfortunate situation there where there is a gap in service, they suffer a disproportionate amount of harm to themselves and their families, and is paid for elsewhere in the system. Let me just finally briefly mention the habilitation autism issue that Ms. Crandy mentioned. It's my understanding that from listening to the committee that we could not have chosen one of the more comprehensive federal plans because it didn't have the autism mandate, and it would have cost us about $4 to $5 billion extra in state funds to cover that. And I questioned that analysis at the last meeting. I've looked into it, and I now agree with Mr. Hager that that is the correct assessment. Mr. Hager also said something, however.
This is LaVon Lewis joining the conference.
Thank you, LaVon.
And sir, if you could wrap it up in 3 minutes, Rob.
I will. In terms of the whether having the autism benefit that we have, whether that is sufficient to cover the required service of habilitative services, because it's restricted just to autism, discriminates against other types of disabilities. I think there's some problems in terms of the federal law on the discrimination provisions, and I ask you to look very closely at that. Thank you very much.
Thank you, Mr. Sasser. Do we have anyone else here in Carson City? And for those on the phone, as soon as we have public comment here in Carson City, I'll take telephone comments. Yes, if you could identify yourself for the record, please.
Good afternoon. My name is Rebecca Gasca on behalf of Elisa Cafferata, President and CEO of Nevada Advocates for Planned Parenthood Affiliates. Ms. Cafferata submitted some written remarks, and my goal here today is to just review those for the public record and for those attending here today who may not have had the opportunity to review those. On the topic of essential health benefits, NAPA has several specific recommendations regarding non-discrimination of the essential health benefits as the portal is built, and we want to provide an overview of the benefits for women in each of the plans. Our written remarks include attachment B, which break down each of the plans by those areas of concern that are most important to us, including mastectomies, kind of a breakdown of maternity in all three plans, family planning, OBGYN, and IVF. Attachment A in our written remarks breaks down kind of cost sharing consistent with women's preventative services guidelines. So we hope that you'll find those helpful. Non-discrimination within the exchange is important because, as you well know, in the 2009 legislative session, the legislature passed the domestic partnership bill, and in the 2011 session added non-discrimination clauses to the public accommodations section of NRS. Of course, hospitals and provision of health benefits are public accommodations, and it's our recommendation that the portal make consistent approaches to provide benefits to LGBTQI individuals in Nevada so that they can better understand their health benefits that are unique to their population, while also allowing them to have coverage under the domestic partnership bill. Plan D, I will note, does cover domestic partners, and so we're happy to acknowledge that, while Plan A1 only covers legal spouse. Plan F1 covers lawful spouse and lawful domestic partner. And as regarding providing coverage without cost sharing consistent with the Women's Preventative Services Guideline, only Plan D will consider prophylactic mastectomy surgery in certain circumstances. And Plan D, however, has a limitation that birth control pills and diaphragms, as well as contraceptive injectables such as Depo-Provera and Lunel, are subject to the plan year deductible. Well, clearly, however, that's not okay under the current guidelines, and so we'll hope that you take that into consideration and add some addendums to ensure compliance with the guidelines that have been issued. Finally, I want to note that while Plan D is clearly the most comprehensive and we could support it, we are a bit concerned about the high deductible as its adverse impact on our clientele and those who traditionally might be served by our programs across the state could suffer some economic consequences as a result of that. Thank you very much.
Thank you. Is there anyone else here in Carson City? If there are any other people here in Carson, if you want to come forward to the testimony table. Okay, looks like you're the last one. If you'll identify yourself for the record, please.
Sure. For the record, my name is Eric Schoen. I'm the director of the Human Services Network. We are a dynamic collaborative of health and human service providers throughout Nevada, primarily Truckee Meadows. We also support the choice of the most comprehensive plan. I think it's an opportunity to seize the moment and really make sure we have a type of health coverage, health insurance coverage that we have long dreamed of for the clients we serve. So I don't know that there's any perfect plan from which to choose, but out of the options that remain, that appears to be the best option. Secondarily, in regard to the habilitative and rehabilitative services, we would encourage a broad, I don't know what the right word would be, but an expansive view in looking at which different disorders would be covered, so it's not only autism, but also perhaps people who have cerebral palsy and other sorts of disorders, so that regardless of what kind of disorder you may fall ill with or have the misfortune of having, that you are covered by the needed habilitative and rehabilitative services to have as meaningful a quality of life as possible. Thank you.
Thank you. All right, I'm going to turn it over to participants that are on the telephone if there's any public comment. And again, for anyone that's joining the line, if you could keep your phone on mute unless you're speaking. Otherwise, we pick up all the background noise in the room that you're in. So with that, I'm going to turn it over to anyone on the telephone that would like to participate in public comment.
Hello?
Yes.
My name is Elise Moss-Bedeker with AMV Healthcare Consulting, LLC, and I would like to thank the board and the committees for their work on the exchange. I have reviewed the essential benefits information, and I fully agree with the comments of John Sasser, Legal Services Statewide Advocacy Coordinator. And I support Plan D because it is the most comprehensive. It offers the best quality of care services to Nevada healthcare consumers, and it best meets the objectives of the Affordable Care Act. It offers the greatest choice, the fewest limits. Thank you for your work and the opportunity to provide public comments. Thank you.
Thank you. Thank you. Any other public comment on the telephone? All right, with that, then we're going to close agenda item number 2 on public comment, knowing that before we adjourn the meeting, we'll have another opportunity for participation in that. So we're going to open up agenda item number 3, which is the discussion and possible action regarding the 10 potential benchmark plans. Mr. Hager, if you want to get started with it, I think Dr. Klein and myself can participate and add to it since we both worked on that subcommittee. But I think the document that I think we want to look at first is really agenda item number 3. It's a 13-page document. The last 2 pages of that document are the recommendation coming up out of the advisory committee. So, John, if you want to kind of walk through the preliminary details of how we got where we are, and then we can entertain some questions from our board members that did not participate in that committee work.
For the record, John Hager, Executive Director. So this is why we're all here today. Selection of the Essential Health Benefits Package, or, excuse me, a recommendation to the Division of Insurance on the state's Essential Health Benefits Package. So this is a quite lengthy report, but I think it's important to step through this so that we all understand and understand what we have to do today, and so that we put to rest some of the inconsistencies or incorrect thoughts about essential health benefits. So again, the purpose of this report is to provide information on essential health benefits. There are attachments, I believe, A, B, and C, perhaps even D. I can't remember off the top of my head. All the way through D. Attachment C include the plan documents. There are 10 plan documents that are provided. Those are all of the benchmark plans. We'll discuss that shortly. The Center for Consumer Information and Insurance Oversight, a division of CMS, has not yet released final regulations for EHB, so we are doing this based on the guidance that we've received so far. There are parts of it that could change. There are items that we've provided in here that are based on information provided verbally from CSIO and CMS, but generally it is all consistent with the bulletins that are out there, and everything is footnoted here. One thing to note, that the actuarial evaluation, when we originally did this, we thought it was the largest. One of the plans was the largest 3 federal plans in the state. It's actually the largest 3 federal plans in the nation. So we substituted Plan H with one of the plans, the standard Plan I. So you'll see in the attachments under item C, and then on page 3, you'll see that Plan H is the federal Blues standard plan. That was, in fact, valued as one of the Blues plans. So it was valued in the actuarial evaluation, but we are replacing the one that was in there. It was the federal HPN plan, which is no longer part of this discussion. So first of all, what is an EHB package? The Affordable Care Act defines it as a set of 10 essential health benefits as a minimum that each plan in the individual and small group fully insured market must cover. So those services include ambulatory patient services, emergency services, hospitalization, maternity and newborn care, mental health and substance use disorder services, including behavioral health treatment, prescription drugs, rehabilitative and habilitative services and devices, laboratory services, preventive and wellness services and chronic disease management, pediatric services, including oral and vision care. Furthermore, the package of essential health benefits must be provided under a typical employer plan, and so what the Secretary of HHS has defined that as a plan that has the same benefits as one of the 3 largest small group insurance products in the state, which are plans A, B, and C, the 3 largest state employee health benefit plans, which are D, E, and F, the 3 largest national federal plan options, G, H, and I, and the largest insured commercial HMO in the state, which is Plan J. To be clear, an EHB package is not, it's a set of covered benefits. It's the items that are covered. It does not take any consideration for cost sharing. So it doesn't matter whether it's a high deductible health plan, a no deductible health plan. Those items are covered in the metal tiers, the cost sharing requirements that are imposed by the actuarial values of the metal tiers. So we're not talking about cost sharing. We are simply talking about what services are covered and what services are not covered. and the extent to which those services are covered. Furthermore, we are not considering eligibility for plans. Eligibility for plans is clearly outlined in the federal regulation, and so whether a plan covers one type of person or another is not applicable here. Those are laid out again in the federal regulations on who is eligible for the advanced premium tax credits. Additionally, we cannot add benefits to the selected plan. If there were a plan that did not cover a category of benefits, then we would be allowed to choose any single category from any other of the benchmark plans. However, all 10 plans cover all of the benefits except for in a couple of cases, habilitative, pediatric dental and pediatric vision, and the replacement of those categories is very specifically laid out in how those will be supplemented, and then we'll get to that in a few minutes. But we cannot pick and choose what benefits we add other than how it's been laid out in the supplementing a category section later on. Finally, it's also important to note that this is the minimum set of benefits that must be provided in the fully insured small group and individual market. We can always add, or excuse me, not we, the plans can always add benefits if they feel that there is a population that they want to serve. So it is simply the minimum. Finally, if we do not select a benchmark plan, if Nevada does not select a benchmark plan, the default is Plan A, which is the HPN point of service plan, and so if we don't select a plan, the set of benefits would come out of that HPN plan. Again, this applies to all carriers that offer health insurance in the individual and small group markets. It does not apply to self-insured plans, to large group health plans, and to grandfathered plans. So even though you might be in an individual market or small group market, if you are on a grandfathered plan, this will not apply to your plan until that plan goes away and you choose a plan that is not grandfathered. Again, this is only a recommendation to the Division of Insurance, and even the division's recommendation to Health and Human Services, to the state, to the Federal Health and Human Services, is a recommendation. While we believe that the federal government will accept the recommendations of the state, it is ultimately the authority of selecting the essential health benefits ultimately rests with the Secretary of Health and Human Services. So the Plan Certification and Management Committee has reviewed this packet and the sets of benefits in attachments A and B, and they have provided their recommendation to the committee. We'll go over those in a minute, or excuse me, to the board. The board will provide a recommendation to the Division of Insurance. Nevada will provide a recommendation to HHS. I believe that you will have an opportunity, if you haven't provided public comment here, there will be stakeholder meetings with the Division of Insurance, and you'll be able to provide public comment to them as they go through their process. We expect that a recommendation will be made by September 30th, although I can't speak for other agencies specifically. And then once the federal government receives all of the essential health benefits packages from all 50 states plus the District of Columbia, they'll write those up, and there will be a public comment period at the federal level. They will take into account all of the input and then turn around and issue a final package for each state, and we believe that will happen sometime in December, although we're not sure. Again, that's up to the federal timetable. So state mandates. The Affordable Care Act indicates that if a state requires a qualified health plan to cover benefits that is not included in the essential health benefits package, the portion of the advanced premium tax credit and cost sharing reductions applicable to the additional benefit shall be paid for by the state. Should Nevada select for its EHB package a benchmark plan that does not include coverage of a benefit mandated by the state would be required to pay the cost of the advanced premium tax credit and cost sharing reduction that would have been paid by the federal government for that benefit. So generally, we went through all the mandates that we could find in statute, and they generally fell into three categories: either wellness, provider parity, or other benefits. And the wellness benefits, they were in sync with the wellness requirements of the Affordable Care Act and the Public Health Services Act. So if they were in line with the required federal wellness requirements, then we did not say that was a mandate in addition to the HB package. If it was a provider parity mandate, it didn't add cost. It doesn't require that you cover a benefit, but simply that if a service is provided by a specialist, not necessarily an MD, and you provide coverage for that benefit, you have to allow that specialist to be part of your network. So, for instance, chiropractic services are not required to be covered in Nevada, but if you cover chiropractic services, you have to allow chiropractors to be on your network in addition to MDs. So that's what a provider parity mandate is. And again, these categories, we created them for the purposes of this report only. You won't necessarily see this anywhere else, but it seemed like a good way to separate out the mandates in the state so that we could clearly define what is and what won't be a cost to the state if we choose that as, depending on what decision we make. So again, nearly all of the benefits mandates fell into either the wellness categories or the provider parity categories. Additionally, all of the mandates that are in place now, that were in place in the first calendar quarter of 2012, and those mandates are what we will base our essential health benefit package for 2014. Currently, there are no additional mandates scheduled to begin after March 31st of 2012. So therefore, the 7 plans, other than the federal plans, the plans A, B, C, D, E, and F, and Plan J include all of the mandates for the state. The concern was, of course, the federal plans that are not required to comply with the state mandates because they're not necessarily offered here. So the first plan, Plan G, did not cover applied behavior analysis therapy for autism spectrum disorders and did not cover the human papillomavirus vaccine. The human papillomavirus vaccine is part of the wellness services, and so therefore we did not cost that one out. However, the plan specifically does not cover applied behavior analysis therapy for autism spectrum disorders. Additionally, Plan H and I do not cover ABA therapies for autism spectrum disorders. Based on that, we found research that indicates that therapy for autism raises premiums by approximately 0.3% to 1%. So there's a range there. Assuming the average monthly premium for an individual is $273 per month, and that is the 2008 data, so that does not include inflation since 2008. And assuming 130,000 and 157,000 subsidized individuals enrolled in the exchange covered in calendar years 2014 and 2015, the cost of the mandate to the state if plans G, H, or I are selected as a benchmark plan is estimated to be approximately $1.3 million to $4.3 million in 2014 and $1.5 million to $5.1 million in 2015. Those ranges are based on the 0.3% to the 1%. And again, we don't want to pick a specific percent. I think the range, it's difficult to tell what that cost might actually be, but those are the ranges that we think that it would cost the state. We're not sure how that would be funded by the state, whether it comes out of the state general fund, some kind of fee, and of course that's a policy decision beyond this board to make a decision or recommendation even on how that is funded. Annual dollar limit substitutions. So there are 2 state mandates that have annual dollar limits. One is coverage for treatment of certain inherited metabolic diseases, and the other is the coverage for autism spectrum disorders. Under the Affordable Care Act, dollar limits for annual dollar limits and lifetime dollar limits go away. We are no longer allowed to apply an annual or lifetime dollar limit. Guidance indicates that plans would be permitted to make actuarially equivalent substitutions within statutory categories. Absent any state statutory language to the contrary, plans would be permitted to impose non-dollar limits consistent with other guidance that are at least actuarially equivalent to the annual dollar limits. However, subsection 4 of the applicable statutes for autism spectrum disorders indicates that plans shall not limit the number of visits an insured may make to any person, entity, or group for treatment of autism spectrum disorders. Therefore, absent any statutory change, the treatment of autism spectrum disorders will be an unlimited benefit beginning January 1st, 2014. Now, we do have a question into the feds to ask them whether or not allowing a plan to make a substitution for an equivalent number of services, if that federal allowance takes precedent over the Nevada statute, or if the Nevada statute takes precedence over the allowance for actuarially equivalent number of services. We don't have that information yet. Furthermore, it could be argued that because plans in effect in the first calendar quarter of 2012 had a $36,000 maximum benefit, which has a theoretical actuarial equivalent number of visits, any number of visits beyond the actuarial equivalent number would be a state mandate above and beyond the selected benefit package of benefits. This would create an increase in premium and therefore an increase in the advanced premium tax credit. Therefore, the amount of this increase may have to be paid by the state of Nevada. Again, we're not sure about the interpretation, and we'll have to get more guidance on that. And so what we've done here is ignored the increase in going from a $36,000 maximum benefit to an unlimited benefit, because all plans would have that difference. The main difference that we see in the plans before us, the 10 plans today, is the difference between that $36,000 maximum for the 7 plans that are in state and the no coverage for the federal plans. So attachment 5D, excuse me, that should be 3D, service level equivalents for autism and meal replacement dollar thresholds, provides information regarding a potential actuarial conversion of the dollar limit to a service limit. However, we don't think that any recommendation regarding this is required from the board at this point for that piece. On the bottom of page 8 and top of page 9, we talk about how we selected the riders that we've included in the analysis. And based on the methodology, we've included 6 applicable riders in the attachments for vision, dental, and mental health and substance abuse services. Additionally, the 3 state plans, D, E, and F, include dental services, which can be found in the plan document for Plan D. And finally, Plan D includes vision services, which are normally included in riders. They're included in that plan document. Supplementing a missing category, as I touched on earlier, if a benchmark is missing a category of benefits, the state must supplement the missing categories using the benefits from any other benchmark option, with a few exceptions to habilitative services, pediatric dental, and pediatric vision. If the habilitative service category is missing, absent a state mandate to the contrary, generally plans specifically cover rehabilitative services but not habilitative services. This requirement is only satisfied if a plan covers both rehabilitative and habilitative services. The treatment of autism spectrum disorders is considered a habilitative service. Therefore, if a plan covers autism spectrum disorders, it can be considered to satisfy this requirement. Pediatric services, including oral and vision care, plans must cover both dental and vision care to satisfy this requirement. Some plans cover these items in the plan document, and some plans cover them through riders. Figure 2 indicates which plans cover pediatric, dental, and vision through either the plan document or the riders. If a state selects a benchmark plan that does not include the habilitative category, which includes the federal plans, habilitative services would be offered at parity with rehabilitative services. A plan covering such services as physical therapy, occupational therapy, and speech therapy for rehabilitation must also cover those services in similar scope, amount, and duration for rehabilitation, or, as a transitional approach, plans would decide which habilitative services to cover and would report on that coverage to HHS, which would evaluate the decisions and further define habilitative services in the future. If a state selects a benchmark plan that does not include the pediatric oral category, and that is plans A, B, and J, the state may select supplemental benefits from either the Federal Employees Dental Vision Program Insurance Program, Federal Employees Dental and Vision Insurance Program dental plan with the largest national enrollment, or the state's separate CHIP program. The EHB definition would not include non-medically necessary orthodontic benefits. It should be noted that FedVIP dental plan covers implants and non-medically necessary orthodontia, which could be considered more expensive than the CHIP program. If a state selects a benchmark plan that does not include the pediatric vision category, the state may select supplemental supplemental benefits from the Federal Employee Dental and Vision Insurance Program Vision Plan with the largest national employment. So again, if the plan covers vision either through a mandate or through its plan documents, we would not supplement that with the FedVIP plan. But if it was not covered in either the rider or the plan document, then you would include it as part of the plan. So we asked Aon Hewitt for an actuarial assessment of the 10 benchmark plan options, and that was designed to provide relative cost of each benchmark plan. Indexing it to the least expensive plan, which is Plan C, received a 1.000. A plan that has a relative index that is higher than that would be more expensive. So if it was a 1.010, it would be 1% more expensive than the lowest cost plan. The highest cost plan here is the Plan D, which has an index of 1.035, which is 3.5% more expensive than the lowest cost plan. So to put it another way, if the state were to choose a plan with an index of 1.035 as its benchmark plan, on average, every plan in the individual and small group fully insured market will cost 3.5% more than if the state were to choose a plan with an index of 1.000. So following the completion of the actuarial assessment, we did additional review based on input from the public and input from the committees, and we've made some adjustments. For riders, the assessment includes the cost associated with all benefits that were included in the plan document, excluding dental, but did not include a valuation of the riders. Therefore, we have added 0.1% to the cost of coverage for each vision rider, and you might notice there was an updated document that was posted for the attachments for Plan C that shows that Plans C, E, and F actually cover corrective lenses through the rider. Plan A does not, so we added 0.1% for Plan A and 0.2% for Plan C, E, and F. And we'll get to the final cost score based on the adjustments from last night. For the FedVIP Vision Plan, because the FedVIP Vision Plan includes corrective lenses, again, we've added 0.2% to the 3 federal plans and Plan J, which must be supplemented with the FedVIP Vision Plan. For mandates, in the case of Plans G, H, and I, we added 0.3% for the cost of coverage. If you remember, we estimated that the cost of coverage was between 0.3% and 1%. So whether or not it should be 0.3% or not, we just for sake of arguments here, we put it at 0.3%. And then for corrections, the benchmark plan and formulary comparison spreadsheet original ones indicate that there are no limit for PT, ST, and OT services for plans A and B, actually in E and J. However, plans A, E, and J have a 60 visit limit, and Plan B has a 30 visit limit. As such, we've added 0.2%, or we've subtracted 0.2% from the relative cost for Plan A, E, and J, and 0.5% was subtracted from the relative cost for Plan B. So with that, we get our relative cost index adjustments. You see that on Figure 3 on page 11. Based on some of the changes that we've discussed, we have a couple of changes to the total cost, and those are Plan E ends up being 1.033, Plan F ends up being 1.020, and Plan J ends up being 1.033. And when we include that in the figure in Figure 4, while it does adjust the total score a little bit, it doesn't affect the ranks, other than the last one ends up being tied for last. So I'll get to that in a second. Additionally, the formulary for each qualified health plan must be similar to that of the selected benchmark plan, and so we reviewed the formularies based on the U.S. Pharmacopoeia Model Guidelines 5.0, and it was included in the actuarial assessment. The set of essential health benefits that we select as a state and are approved by HHS are in place for calendar years 2014 and 2015. HHS intends to release further guidance for 2016 and beyond. We're not sure how that will end up, whether it will be an iterative approach or a brand new selection, but we'll wait to hear from them. I would expect to receive that sometime next year. So the selection of Nevada's package of essential health benefits, we asked the committee to review the key principles that were approved by the board in April. You see the 8 of them listed on page 12, and then kind of combine them into including state mandates, being minimally disruptive, providing comprehensive coverage, and being affordable. The committee eliminated the federal plans because they did not include the state mandates. They wanted to make sure that they were in line with the will of the legislature and did not add additional cost to the state. Based on the remaining 3 categories and the key principles, the committee approved a weight for each of the 4 categories and a score for each of the 7 plans, from 1 being least favorable to 5 being most favorable. The plans were scored and weighted as follows. Minimally disruptive plans, 20% of weight. Higher scores were given to the small group plans and HMOs, as they are more typical of the small employer and individual markets. The Anthem PPO was given a lower score because of the disruption that may be caused by the generic-only formulary. Comprehensive, higher scores were given to plans that had fewer exclusions. No adjustment was made if a plan was missing a category, as that plan would be supplemented as appropriate. Affordability, 40% weight. Higher scores were given to plans with lower costs in the actuarial valuation after adjustments. Plan D and J received the lowest scores of 1.0 due to the high cost of 1.035, and then the affordability scores were calculated using that formula that you see at the bottom of page 12. So on figure 4, you see the various scores based on the changes to the previous table. The affordability score for Plan E went up to 1.2, Plan F went up to 2.8, and went down to 2.8, and Plan J went up to 1.2, changing their total scores to 2.50, 3.13, and 2.50. However, the rankings remain the same. Plan J with a rank of 7 actually is tied now with Plan E with a rank of 6. It should be noted that the disruption and the comprehensiveness were fairly subjective evaluations, and there's even some debate whether or not the indexing for the affordability is accurate given some of the differences in the plan designs. The committee selected for the board's consideration the top 3 scoring plans: Plan A, which is the HPN point of service plan; Plan D, which is the Nevada PEB high deductible health plan; and Plan F, which is the Nevada hometown health plan with PEB. Additionally, the committee recommended that if the board selected Plan A as its recommended benchmark plan, the plan should be supplemented with the Nevada CHIP dental plan. That would align those children that are in CHIP when they go out of CHIP, their dental benefits would be as closely aligned as possible and reduce potential churn issues. With that, I'd like to turn it over to the board for questions and comment.
All right, thank you, Mr. Hager. Again, I'd like to kind of recap just 3 important parts of the work that the committee did, and one of them is to remind everyone, as Mr. Hager said, the essential health benefits package is the minimum standard that the state needs to look at. Second is to remember that although this board is considering a recommendation, we do not make the final choice on this. That lies with the Commissioner of Insurance, who has been working very, very closely with us since day one. The Commissioner was at our last meeting on September 13th and gave us kind of an idea of what he thinks he'll be doing through the rest of the month on this, and it's my understanding that he's going to attempt to have public meetings not only in Las Vegas and Reno, but will be attempting to have meetings out in Elko so that they get a broad overview of public comment. And third, and probably one of the items that really hits home in Nevada with the economic struggles that we've had is the reason why we eliminated the federal plans. And that was because those plans do not consider any of the mandates that the state legislature has put in place for the state of Nevada. If we chose one of those plans, the cost of those mandates would come directly from the general fund. And I think everyone felt a huge fiscal responsibility to make sure that we are not making a recommendation that's going to hurt Nevada economically. So, Mr. Hager?
And I would also like to point out that we have a representative from United on the phone, which would represent the HPN plan. Dr. Ash Jackson from Hometown Health is here, and Donna Lopez from the PED PPO plan is here as well. They are the best in their fields with their plans. So if there's a question to be asked, they know the answer.
And then lastly, there isn't any reason that this board could not continue in the same direction that the advisory committee did, and that would be to make a recommendation up to the Commissioner of Insurance that would include 1, 2, or 3 possible plans for his consideration. So it is not mandatory that we pick only one plan today. So with that, I'm going to open it up for discussion from board members. If you want any of the representatives to answer questions, we'll have them come forward to the testimony table. With that, I'm going to kick it down to Las Vegas and ask Ms. Johnstone if she'll help me manage down there.
I'll start with the question, Madam Chair. This is Leslie Johnstone, and it might be a little bit in the weeds, but in terms of lifting any annual or lifetime dollar limits and visit limits, I'm thinking of some of the plans have annual or lifetime limits on for chiropractic or the gastric bypass surgery dollar amount limits. Do all of those get lifted because of requirements in the ACA?
For the record, John Hager, so there will no longer be any dollar limits. However, if there is a plan, let's say a plan offers a $1,000 chiropractic benefit, and I don't know how many services, let's just pretend it's 10 services. I have no idea what that's correct or not. If a plan offers a $1,000 benefit, chiropractic benefit, and that's the essential health benefit package that we select, then all plans will be required to offer the chiropractic service at a similar level to that $1,000 benefit. So while it wouldn't be limited to $1,000 at that point, if the plan says that's actuarially equivalent to 10 services, then the new limit would be 10 services as a minimum for all plans in the state. Now, that could be different between the north and south. Services tend to be more expensive up here in the north than they are in the south, so an actuarially equivalent number of services could be different in the north and the south, and I haven't seen any specific interpretation on that. I hope that answers your question.
It does. Just point of clarification. So the dollar limit gets lifted, but the plans can apply an actuarially equivalent limit in terms of the number of services?
Yes, that's our understanding.
Thank you.
Any other questions?
Madam Chair, Lynn Atkins.
Yes, Ms. Atkins.
So could someone, and maybe that's you, John, could you highlight the differences, between the 3 that were recommended? Maybe just highlight what the committee thought are the more important differences just between the 3, so we could focus on the 3, or at least that's what I would like to focus on, is those 3.
So the updated document that was provided last night includes those items. Plan A has 60 visits for PTSD-OT. Plan D has no mention of limits, and Plan F has 30 limits for each. Should be noted that the 60 limit for Plan A is combined for all 3 of those, whereas the 30 visit limits for Plan F are per category. There's a 100-day limit for skilled nursing facilities in Plans A and F. For Plan A, 30-day limit for Plan F, and a 60-day limit for Plan D. Rehabilitation in hospital is 60 in Plan A, no mention of limits in Plan D, and 30 days in Plan F. We go down to bariatric and weight loss. So I would like to say that the items that were provided here, the ones in red are added items or changed items from the previous report. The committee did, in fact, consider the changes in the PTSD and OT services. We added a couple of additional items that the committee didn't consider. One was bariatric and weight loss, a $5,000 lifetime surgery for surgery and complications for item A. Plan D, they indicated that there were no specific limits, and maybe, Donna, there was a limit put in place recently. Is that effective in July? Was it effective in the beginning of this calendar year, or did it start in July? This past July, 2012. So for the plan, the essential health benefits package here is not the same as it is as the plan is today. There are no limits for bariatric here. And then for Plan F, I believe that is $20,000 hospital for surgery and $50,000 to $150,000 for complications. We see the chiropractic. There's a $1,000 limit per year, $5,000 for the lifetime for Plan A, no limits for D, and $1,000 for Plan F. Hearing aids has been a controversial issue. There's a lot of public comment on hearing aids and vision. The hearing aids, Plan A has a $5,000 limit per year, replacement every 3 years. Plan D has no mention of limits, and Plan F, the Hometown Health Plan, does not cover hearing aids. For optometry exams, Plan A includes one routine exam every 12 months. Plan D includes, I believe it's the same, about one exam every 12 months. And Plan F also has one routine exam every 12 months. Also, Plan F includes corrective lenses. I think it was the only plan that actually included corrective lenses. No, let me correct myself. Eyewear, there is a rider for Plan. Eyewear is not covered for Plan A. Plan D, the initial contacts or eyeglasses are covered following cataract surgery, but otherwise they're not covered. And for Plan F, again, it is covered with no mention of limits. Hearing exams generally were not covered unless medically necessary. Plan D does include regular hearing screenings. Mental health and substance abuse categories, there were no limits on inpatient or outpatient treatment for severe mental health, only severe mental health covered inpatient, and SA covered without limits. On Plan D, no limits on inpatient or outpatient treatment, and for Plan F, no limits again on inpatient or outpatient treatment. TMG had a $2,500 a year, $4,000 lifetime maximum for Plan A, no mention of limits for Plan D, and no mention of limits for Plan F. And then finally, infertility, medically necessary. It had to be for Plan A, had to be medically necessary, include labs, diagnostics, and 6 artificial insemination cycles per member per lifetime. Plan D was limited to diagnosis only, but no limit on diagnosis. And Plan F had a $2,500 lifetime maximum for diagnosis only. So those were the major differences that we could identify here that we felt had an impact or a significant impact on cost. There might be other differences that we didn't identify here that we felt were too small to cost out.
Thank you, John. Madam Chair, may I just ask one other question at this time?
Go ahead, please.
So on the cost, and I'm looking now at page 4 of the actuarial assessment. If we're just looking at plans A, D, and F, then, and again, that's at least what I'm doing. So, Plan A if Plan A is now the baseline, Plan F is 0.2% more in costs, and Plan D is 1.7% more in costs. Is that correct?
Yeah, it's pretty close.
This is Lavon Lewis. Would you repeat your question, since I did not hear the question, so I'm listening for the answer.
The question was on the actuarial evaluation report for the combined relativity medical and RX. If we're considering plans A, D, and F, Ms. Edkins wanted to confirm which plans were, what were the differences in the plans. So at 1.016, Plan A was the least expensive plan. Plan F was 0.2% more than Plan A, and Plan D was 1.9% more than Plan A.
9, did you say?
1.9%.
Thank you very much. There's a lot of static, and I can't hear any of the comments that are coming from the Las Vegas office. Thank you.
Any other questions out of Las Vegas?
Doesn't look like it, Madam Chair.
All right, Dr. Klein, do you want to add any comments because you participated in these this committee?
Just very briefly, just to how I got to where I am right now, and how the committee got, I think, to its recommendations. We took the 3 federal plans and crossed those out because of the impact to the states. That left us with 7 plans. I personally cut out Plan B and C since they were 1 and 2 in comprehensiveness. I felt that was the wrong thing to do. So that left us with 4 level 3 plans plus Plan D, which was the most comprehensive but also the most expensive. So that's 5 plans. Of the 4 level 3 plans, A, E, F, and J, A was valued at 1016, E 1033, and I might be off by a tenth because you've changed things now, or a hundredth, but F was 1018 and J was 1033. So, and again, this is all subjective based on John's review of the plans. And by the way, we should thank John for spending many evenings with plan documents, something only a CFO could love. Because E and J were the most expensive of the level 3s, I personally crossed those out, and that left me with A and F. And then we also talked about D as being the most comprehensive but also the most expensive by 1 or 2%. So in real terms, we're talking about $20 per $1,000 in terms of what you're going to pay. So that left us with A, F, and D. As I look at the plans now myself, really focusing in on A and F, it seems that F is the better of the 2 plans compared to A, with the exception that A covers hearing aids while F does not. And that's sort of obviously a very important thing to those who need them, and probably will be more important as the population ages. So that's sort of, I'm sort of at A, F, and D as sort of how we got to that point.
Thank you, Dr. Klein. I think I'd like to go into the discussion a little bit of why we decided not to pick just one plan at the committee level. And as Dr. Klein indicated, the more comprehensive the plan became, the trade-off was it became the most expensive plan. So knowing that Plan B was the most comprehensive, we certainly wanted to make it part of the mix, knowing that it potentially could be the most costly of the plans as well. Secondly, from that point, then we went to what were the next 2 most comprehensive plans, and those were A and F. And with that, the affordability test came up higher for those 2 plans. I think that the committee felt, knowing that they were not going to be the ultimate decision maker, that they wanted to offer to this board 3 different plans that they felt met the principles of the committee and the affordability component of the act itself. So with that, knowing that this board does not make the ultimate decision, I guess I'd like to open up for discussion among the board members whether or not you want to pick one single plan, or do you agree with the philosophy of picking 2 or 3 to send on up to the Commissioner of Insurance?
I'm Chairman Lavon Lewis. Before we move there, could I get could I ask another question, or the repeat of an answer rather? There was some discussion about the mental health coverages between plans A, D, and F. Could I hear those again?
Yes, we'll have Mr. Hager go over that again, and that
Tell me where I can go and find it in the documents. But
yeah.
I thought that it's easier for me to hear it again.
Okay, why don't we have Mr. Hager direct us to the exhibit on the agenda, and then he can go over it with you as well.
So on the website, that document is plan. It's the third plan 3 or item 3B. It says benchmark plan comparison update. So we provided the original one in PDF and Excel if you wanted to view it in Excel, and then finally the third one is the benchmark plan comparison update, which updates pages 3 and 4 of the original document. So that document you'll see has red and black font. For mental health and substance abuse categories, it appears that Plan A has no limits on inpatient or outpatient treatment for severe mental health. Only severe mental health covered inpatient. Says no limits on inpatient or outpatient treatment for Plan D, and Plan F appears to also have no limit on inpatient or outpatient treatment for mental health and substance abuse categories.
Does that help, Ms. Lewis?
Yes, it did. Thank you very much.
You're quite welcome.
Madam Chair,
Madam Chair, this is Wayne Finch representing United Healthcare Health Plan of Nevada. May I make a comment regarding the comments here?
No, this is not public comment time. We need to wait till after that.
He's one of our experts.
All right.
Okay.
Madam Chair?
Yes.
Lynn, I'm sorry, I have one other question before. I know you posed a question about making recommendations. I do have one other substantive question.
Sure.
Again, I'm sorry. Can we go over the drug formulary differences between the 3 plans as well?
And do you want to take us to the exhibit too,
So that would be the first 3B, which is the benchmark plan and formulary comparison, and it starts on, I believe, page 5 and goes through the end of the document, which is about page 30. Is there something specific that you would like to see for that?
I don't know. I don't think there's something specific. I guess a summary, if it's possible. Again, it's just I think, at least for me, since I was not in the subcommittee meeting, I think I just need a little bit more guidance and information than maybe the rest of you. I'm not sure or maybe the highlights about what was discussed about the drug formularies, the differences, or some concerns that may have been raised.
The committee really didn't go through the drug formulary, if I recall.
No, and I think the comments made, Ms. Atkins, about the drug formulary was, it really is specific to the patient and what their drug needs are, so that when you get onto the website trying to make a choice of plans, the intent is for you to be able to list off your drugs so it can guide you to the appropriate plan that has coverage on those drugs.
Right, and I guess though that one of the plans though was taken off the consideration list because it was generic only. So is that not the case with the ones we're considering?
Yeah, Plan C, Plan C. In John's analysis, the Anthem PPO generic treatment got the lowest score for being minimally disruptive, and and is also least comprehensive. And my recollection was the reason, John, that you made it the sort of double negative. You gave the lowest score for being minimally disruptive was that because of the generic formulary.
That's correct, Dr. Klein.
So if we go through the attachment 4, which is the It's item 3B, and it's the fourth part of that long spreadsheet. So the last 2 pages, we see that Plan D and F do not cover certain antibacterials. None of the 3 plans cover antifungals. Plan A does not cover anti-migraine agents. Plan F does not cover antiparasitics. And I believe it's only certain categories. Oh, so I'm getting waved off by the experts here. I basically have no business looking at this formulary. we did give a low score to the Plan C because it was generic only, because of concerns with coverages. The expert from Hometown Health is indicating that they cover everything apparently. And I believe the gentleman from Hometown or from United has a comment about the HPN option. If we want to ask him.
If it's all right with board members, I'll open it up from the 3 different potential providers to answer that question.
Madam Chair, can you repeat the question, please?
Question was the differences in the formularies with respect to prescription care.
Thank you.
Madam Chair, it's Ron Klein.
I think that's Dr. Klein.
I'm sorry, is there somebody who's getting ready to speak? If so, then I'll hold off.
Yes, we have. I'm going to have them introduce themselves for the record, and we do have someone on the phone from United. Who is on the phone from United?
This is Wayne Finch.
All right, thank you, Mr. Finch. I appreciate it. Now is the time for you to speak. And then we have here in Carson City.
I think it's on. For the record, my name is Donna Lopez, and I'm the Quality Control Officer for the Public Employees Benefits Program. And in regards to the formulary that the PEB plan currently uses, there are some medications that are non-formulary, and they are non-preferred brand name drugs only. But for the most part, the formulary is extremely broad. And if it's okay with Madam Chair, can I make a comment on something that a commenter previously made in regards to certain reproductive medications that are not currently listed on our plan?
Okay.
And the federal mandate indicates that a health plan must implement that benefit upon its renewal after, and I can't remember the exact date, it's August, after 8/1 of 2012. The PEB plan year does not renew until July 1 of 2013, so those benefits will be included in our PPO plan.
Thank you. Dr. Jackson.
Thank you, Madam Chair. Dr. Linda Ash Jackson, Medical Director of Hometown Health. The formulary that we use for the state of Nevada is our commercial formulary. And although there are limitations on what drugs are formulary and non-formulary, every class of drug is covered at a benefit, much like the formulary that the PEB formulary has. And the formulary that was provided for review and the plan was the 2011 plan formulary, and we chose to implement the Women's Preventive Health Benefit for the state as of 7/1/12. So all of the medications that were deemed to be part of the Women's Preventive Health to be covered at no copayment were included in the formulary that is implemented for the state of Nevada HMO as run by Hometown Health as of 7/1/12, and the actual benefits including birth control, implants, tubal ligation, etc., breast pumps, everything that was either not covered or had a copay before is being covered at 100% as well.
Okay. Mr. Finch?
Hi, thank you, Madam Chair. Yes, our comments and handling of the formulary is very consistent with Dr. Linda Ash Jackson from Hometown Health Plan. The formulary that's being used right now under Plan A is our commercial formulary. It includes drugs under each of the major therapeutic areas and includes all of the expansions to include women's health effective July 1, 2012 as well. So very, very similar comments.
Thank you, Mr. Finch.
Madam
And
Chair?
I have both of, yes, Dr. Klein?
I'm sorry, I don't mean to be interrupting here. Is everybody concluded, or?
No, I just wanted to ask the three participants to stay at the testimony table or on the phone, so if we had additional questions. So, Dr. Klein, do you have a question?
No, I'd like to make a motion if I might.
All right.
Okay, first off, the cliche that keeps popping into my head as we have this discussion is that perfect is the enemy of good, and try as we might, I think that all the different plans have positives and negatives. I think the second point is that the decision we're going to make now is basically effective for 2 years, for 2014 and 2015. And if there are serious problems with one of the essential health benefit packages that we choose, then we can change that effective 2016 by rules that have yet to be elucidated by the federal government. But I think we will be able to change them in 2016. So I think review will be very important. I do want to publicly commend John Hager for spending enormous amount of time reviewing these plans and appreciate the work he's done. Having said that, I compliment the chair for recommending that we choose multiple plans that we recommend to the insurance commissioner as opposed to trying to figure out a single one. I think the insurance commissioner will pick one, I'm sure with the governor's advice, and then the Secretary of Health and Human Services may or may not overrule that. So it's a long process. Having said that, I would recommend that we recommend one of three plans to the Commissioner of Insurance, those plans being F, A, and D.
Thank you, Dr. Klein. Do we have a second to the motion?
I'll second, Madam Chair. This is Leslie Johnstone.
Thank you, Ms. Johnstone. Do we have any further discussion before I call for the vote? And I'll do a roll call vote on this. I'll have Mr. Hager call for the roll call vote.
Ms. Edkins?
Yes.
Ms. Lewis?
Yes.
Dr. Klein?
Yes.
Ms. Kerr?
Yes.
Dr. Ford?
Yes.
Vice Chair Johnstone?
Yes.
And Chair Campbell?
Yes.
It's unanimous.
Thank you. We have a unanimous vote to send forth to the Commissioner of Insurance our recommendation of plans A, D, or F as our recommendation from the Health Insurance Exchange. I will go ahead and close agenda item number 3. Oh, there is one other thing. Plan A is missing.
Correct.
One writer, so we need to have a motion to adopt. The recommendation from the committee was to adopt the Nevada CHIPS program.
Correct.
Lynn Atkins, so moved.
Do we have a second?
Dr. Ford, I second.
Thank you. I think I'll just do a vote approval or a voice approval on this one. All in favor?
Aye.
Any opposed? The motion, again, carries unanimously. So with that, we'll go ahead and close agenda item number 3 and open up agenda item number 4 for public comment. Again, is there any public comment in Las Vegas?
No, Madam Chair.
Is there public comment? We have the Commissioner of Insurance with us here. Mr. Kipper, welcome.
Thank you, Madam Chair. For the record, Scott Kipper, Insurance Commissioner, and I apologize for being so tardy, but I did want to say on the record today that I and my staff certainly appreciate the thoroughness that you've tackled the essential health benefits I was going to say conundrum. And certainly I do appreciate the cooperation and process, and certainly do everything in our power to make sure that a good product is picked and recommended on behalf of Nevada and certainly on behalf of the board. So thank you so much for your good work.
Mr. Commissioner, thank you for your compliment, and thank you for assisting us through this. We look forward to seeing the progress over the next month and seeing what your decision will be.
Thank you.
Thank you. Do we have anyone else here in Carson City that would like to take advantage of public comment? How about on the telephone?
This is Yvonne Lewis, and I would just like to compliment Commissioner Kipper and Mr. Hager for their presentation in the community last Saturday, giving people information about the Affordable Care Act and what progress we are making. And I think that they did an excellent job of giving the community information, and I'm sure going forward as we do that more and more, the community will become more aware. So thank you very much, those of you, for your presentations. We really appreciate it.
Thank you, Ms. Lewis. I know everyone appreciates your comments on that, too. Do we have anyone else on the telephone that would like to have public comment?
Madam Chair?
Yes.
My name is Ken McAleese, and I don't have an agenda in front of me, so I may be speaking out of turn. If you see a better place for me in the agenda, you can let me know. But I was wondering if I had an opportunity to offer a comment on any service level equivalents for autism and ABA dollar thresholds.
This is public comment. You're welcome to say anything, and you're limited to 3 minutes. You may also submit anything you'd like to Mr. Hager, and we'll put it up on our website.
Thank you. I do have there is a member there who can submit a letter that was signed that I had sent down there with me. So I'll read it to you guys today. I've recently been made aware that as insurance health exchanges are being developed in the state of Nevada, that an issue
Can I get you to get closer to your microphone? We can't hear you.
Yeah, yes, ma'am. Can you guys hear me now?
Yes, that's much better. Thank you.
Again, my name is Dr. Ken McAleese. I'm a licensed behavior analyst with Advanced Child Behavior Solutions. I have recently been made aware that as health exchanges are being developed in the state of Nevada, an issue concerning the number of visits or sessions regarding treatment for autism spectrum disorders is being reviewed. A number of problems may be raised depending on how visits or sessions are defined. A volume of research on ASD treatment informs us that a typical maximum dose for a young child with ASD may be as much as 40 hours of treatment per week. The research does not list visits or sessions in its language. Treatment for many children can occur every day of the week, starting early in the morning and ending in the evening. Multiple providers may provide this treatment in a day. A typical treatment team would be comprised of a licensed behavior analyst and 3 to 5 other certified autism behavior interventionists. So a child may receive multiple hours, multiple times a day for multiple hours at a time. I bring this to the attention of the board because many of the regional carriers who are probably proposing plans have struggled to understand how the results of our individual state mandate, AB 162, which was passed in 2009 and has been implemented for, I guess, now about 20 months now. We're in, as it started and it was enforced in 2011. But in concerns about session limits, and I did not hear any listed by Mr. Hager regarding autism coverage with the plans that he discussed. However, I have concerns about that, and I would like to see that there would be a maximum, if they does have a daily treatment, of 365 visits. If it's a daily visit requirement. If it's a per session, per provider requirement, there's a suggestion in the language that we could include 20 visits per week, which again is the optimal amount that's suggested by the research. And from what was provided to me by members of the Autism, the Nevada Autism Insurance Commission, the Nevada Autism Commission, the Nevada Commission on Autism Spectrum Disorder, sorry guys, a lot of words today, that there may be some inaccurate cost actuarial data from the insurance companies around ABA and autism therapies in Nevada, and may be inaccurate with respect to who is providing the therapy and the dose. We're still working on building the regulations and the process around this, and so the confusion regarding some of it is pretty clear. What I'm asking the board to do is to look carefully at the particular plans, and if there's opportunities to revise or update session limits or other items to reflect best clinical practices and ensure that the patients in Nevada are receiving the optimal treatments that they need. That's all I had. Thank you, guys.
Thank you very much. Do we have anyone else on the telephone line for public comment?
Yes, this is Elise Moss-Medica with AMV Healthcare Consulting.
Could you get a little bit closer to your telephone mic?
Okay, how about this?
That's much better. Thank you.
Okay, Elise Moss-Medica with AMV Healthcare Consulting, LLC. The three recommended plans all have their pros and cons, and of the three plans, I did not hear address what happens if of the three, one plan is selected. Is there any consideration given to services that are not provided in the state of Nevada, where a consumer would have to go to another state, a neighboring state, for services? For example, someone in Elko, they're closer to Utah, or if a person needs a transplant and we don't offer it here in Nevada, they may have to go to California. How is that being addressed in these plans? That is my question for consideration, or to take that into consideration. Thank you.
All right, thank you for that. If you want to put that in writing and direct it to Mr. Hager, we can try and address that at a future meeting.
Okay.
Do we have any other public comment? Hearing none, I'm going to close the agenda item for public comment and thank everyone for their attention and their participation, and thank the board members for their preparation for today. And thank you, Mr. Hager, and your staff for all the hard work that you've done getting us to this point today. And with that, we'll toss it off to Commissioner Kipper, and we'll adjourn our meeting today. Thank you.